Hello everyone, and welcome back to another chapter of Advanced Pharmacology. Today we're talking about Unit 7 psychotherapeutic drugs. Specifically, we'll be touching up on Chapter 27, our sedative and hypnotic drugs. The sedative hypnotics are drugs that depress central nervous system function. With some of these drugs, CNS depression is more generalized than with others. The sedative hypnotics are used primarily for two common disorders: anxiety and insomnia. Agents given to relieve anxiety are known as anti-anxiety agents or anxiolytics. Agents given to promote sleep are known as hypnotics. The distinction between anti-anxiety effects and hypnotic effects is often a matter of dosage. Typically, sedative hypnotics relieve anxiety in low doses and induce sleep in high doses. Therefore, a single drug may be considered both an anti-anxiety agent as well as a hypnotic agent, depending on the reason for its use and the dosage employed. There are three major groups of sedative hypnotics: barbiturates, benzodiazepines, and benzodiazepine-like drugs. The barbiturates were first introduced in the 1900s, the benzodiazepines in the 1950s, and the benzodiazepine-like drugs in the 1990s. Although barbiturates were widely used as sedative hypnotics in the past, they are rarely used for this purpose today, having been replaced by the newer drugs. Before the benzodiazepines became available, anxiety and insomnia were treated with barbiturates and other general CNS depressants, drugs with multiple undesirable qualities. First, these drugs are powerful respiratory depressants that can readily prove fatal in overdose. As a result, they are a choice of drug for suicide. Second, because they produce subjective effects that many individuals find desirable, most general CNS depressants have a high potential for abuse. Third, with the prolonged use, most of these drugs produce significant tolerance and physical dependence. And fourth, barbiturates and some other CNS depressants induce synthesis of hepatic drug metabolizing enzymes and can therefore decrease response to other drugs. Because the benzodiazepines are just as effective as the general CNS depressants, but do not share their undesirable properties, the benzodiazepines are clearly preferred to the general CNS depressant for treating anxiety and insomnia. We begin by discussing the basic pharmacology of the sedative hypnotics, and at the end, discussing their use in insomnia. The use of these drugs for anxiety disorders was already addressed in Chapter 28. So, we'll start off by talking about benzodiazepines. Benzodiazepines, along with the newer benzodiazepine receptor agonists, are drugs of first choice for anxiety and insomnia. In addition, these drugs are used to induce general anesthesia and to manage seizure disorders, muscle spasms, and withdrawal from alcohol. Benzodiazepines were introduced in the late 1950s and remain important today. Because the most familial member of the family is diazepam or Valium, and the most frequently prescribed member is lorazepam or Ativan, as well as alprazolam or Xanax. Because all of the benzodiazepines produce nearly identical effects, we will consider the family as a group, rather than selecting a representative member as a prototype. Overview of the pharmacologic effects. Practically all responses to benzodiazepines result from the action in the CNS. Benzodiazepines have few direct actions outside of the CNS. All of the benzodiazepines produce a similar spectrum of responses. However, because of the pharmacokinetic differences, individual benzodiazepines may differ in clinical applications. So, the central nervous system. All beneficial effects of benzodiazepines and most adverse effects result from depressant action in the CNS. With increasing dosage, effects progress from sedation to hypnosis to stupor. Benzodiazepines depress neuronal function at multiple sites in the CNS. They reduce anxiety through effects on the limbic system, a neuronal network associated with emotionality. They promote sleep through their effects on the cortical areas and on the sleep-wakeful clock. They induce muscle relaxation through their effects on supraspinal motor areas, including the cerebellum. Two important side effects, both confusion and anterograde amnesia, result from the effects on the hippocampus and cerebral cortex. Effects on the cardiovascular system. When taken orally, benzodiazepines have almost no effect on the heart and blood vessels. In contrast, when they are administered intravenously, even in therapeutic doses, benzodiazepines can produce profound hypotension and potential cardiac arrest. Effects on the respiratory system. In contrast to barbiturates, the benzodiazepines are weak respiratory depressants. When taken alone in a therapeutic dose, benzodiazepines produce little or no depression in respiration. And with toxic doses, respiratory depression is moderate at most. With oral therapy, clinically significant respiratory depression occurs only when benzodiazepines are combined with other CNS depressants, such as opioids, barbiturates, or alcohol. Although benzodiazepines generally have no minimal effect on respiration, they can be a problem for patients with respiratory disorders. In patients with chronic obstructive pulmonary disease, benzodiazepines may worsen hypoventilation and hypoxemia. In a patient with obstructive sleep apnea, benzodiazepines may exacerbate apneic episodes. In patients who snore, benzodiazepines may convert partial airway obstruction into OSA. So, let's talk about the molecular mechanism of action, therefore. Benzodiazepines potentiate the action of gamma-aminobutyric acid, or GABA, an inhibitory neurotransmitter found in the CNS. These drugs enhance the action of GABA by binding to specific receptors in a supramolecular structure, known as the GABA receptor chloride channel complex. Note that benzodiazepines do not act as direct GABA agonists. They simply intensify the effects of GABA. Because benzodiazepines act by amplification, the actions of endogenous GABA, rather than by directly mimicking GABA, there is a limit to how much CNS depression benzodiazepines can produce. This explains why benzodiazepines are so much safer than a barbiturate, drugs that can directly mimic GABA. Because benzodiazepines simply potentiate the inhibitory effect of endogenous GABA, and because the amount of GABA in the CNS is finite, there is a built-in limit to the depth of CNS depression that benzodiazepines can produce. In contrast, because barbiturates are direct-acting CNS depressants, maximal effects are limited only by the amount of barbiturate administered. So, it's pharmacokinetics. Its absorption and distribution. Most benzodiazepines are well absorbed after an oral administration. Because of their high lipid solubility, benzodiazepines readily cross the blood-brain barrier to reach the site in the CNS. Its metabolism. Most benzodiazepines undergo extensive metabolic alterations. With few exceptions, the metabolites are pharmacologically active. As a result, responses produced by administering a particular benzodiazepine often persists long after the parent drug has disappeared. Therefore, there may be a poor correlation between the plasma half-life of the parent drug and the duration of the pharmacologic effect. Flurazepam, for example, whose half-life is only 2 to 3 hours, is converted into an active metabolite which has a half-life of almost 50 hours. Therefore, giving flurazepam produces long-lasting effects, even though flurazepam itself is gone from the plasma in 8 to 12 hours. In a patient who has liver disease, metabolism of benzodiazepines may be reduced, thereby prolonging excretion and intensifying responses. Because certain benzodiazepines, such as oxazepam, temazepam, and lorazepam, undergo very little metabolic alteration, they may be preferred for a patient who has hepatic impairment. The time course of action. Benzodiazepines differ significantly from one another with respect to time course. Specifically, they differ in onset and duration of action and in their tendency to accumulate with repeated dosing. Because all benzodiazepines have essentially equivalent pharmacologic actions, Selection among them is based largely on differences in time course. For example, if a patient needs medication to accelerate falling asleep, a benzodiazepine with a rapid onset would be indicated, such as triazolam. However, if a medication is needed to prevent waking later in the night, a benzodiazepine with a slower onset would be preferred, such as istazolam. For treatment of anxiety, a drug with an intermediate duration is desired. For treatment of any benzodiazepine-responsive condition in older adults, a drug such as lorazepam, which is not likely to accumulate with repeated dosing, is generally preferred. So therefore, its therapeutic use. The benzodiazepines have three principal indications. Again, anxiety, insomnia, and seizure disorder. In addition, they are used as preoperative medications and to treat muscle spasms and withdrawal from alcohol. Although all benzodiazepines share the same pharmacologic properties and therefore might be equally effective for all applications, not every benzodiazepine is actually employed for all potential uses. The principal factor that determines the actual application of a particular benzodiazepine are first, the pharmacokinetic properties of the drug itself, and second, research and marketing decision of pharmaceutical companies. So the specific applications of individual benzodiazepines are shown in the following table here. So here's an excellent spot to hit pause so you can see the application of different kinds of benzodiazepines, whether it's for GAD, insomnia, seizures, muscle spasm, spasticity, alcohol withdrawal, or anesthesia, or induction, or pre-anesthesia, and lastly for anxiety. So speaking on each application, anxiety. Benzodiazepines are drugs of first choice for acute anxiety. Although benzodiazepines have anxiolytic actions, only 6 are marketed for this indication. Anxiolytic effects result from depressing neurotransmission in the limbic system and cortical area. The use of benzodiazepines to treat anxiety disorders is discussed in Chapter 28. Insomnia. Benzodiazepines are also used to treat insomnia. These drugs decrease latency time to falling asleep, reducing awakenings and increasing total sleeping time. The role of a benzodiazepine in managing insomnia is discussed in depth later. Seizure disorders. 4 benzodiazepines, diazepam, clonazepam, lorazepam, and chlorazepate, are employed for seizure disorder. Anti-seizure applications are discussed in Chapter 19. Muscle spasms. One benzodiazepine specifically, diazepam, is used to relieve muscle spasms and spasticity, which was discussed in Chapter 20. Effects on muscle tone are secondary to action in CNS. Diazepam cannot relieve spasms without causing sedation. And finally, alcohol withdrawal. Diazepam and other benzodiazepams may be administered to ease withdrawal of alcohol, which was discussed in Chapter 31. Benefits derive from cross-dependence with alcohol, which enables benzodiazepines to suppress symptoms brought on by alcohol abstinence. But that doesn't mean there are not adverse effects. Benzodiazepines are generally well tolerated, and serious adverse reactions are rare. In contrast to barbiturates and other general CNS depressants, benzodiazepines are remarkably safe. So, its adverse effects on the central nervous system via depression. When taken to promote sleep, benzodiazepines cause drowsiness, lightheadedness, incoordination, and difficulty concentrating. When these effects occur at bedtime, they are generally inconsequential. However, if sedation and other manifestations of CNS depression persist beyond waking, interference with daytime activities may result. Anterograde amnesia. Benzodiazepines can cause anterograde amnesia, so the impaired recall of events that take place after dosing. Anterograde amnesia has been especially troublesome with triazolam or halcyon. If patients complain of forgetfulness, the possibility of drug-induced amnesia should be evaluated. Sleep driving and other complex sleep-related behaviors. Patients taking benzodiazepines in sleep-induced doses may carry out complex behaviors and then have no memory of their actions. Reported behaviors include sleep driving, preparing and eating meals, and making phone calls. Although these events can occur with normal doses, they are more likely when doses are excessive and when benzodiazepines are combined with alcohol or any other CNS depressant. Because of the potential for harm, benzodiazepines should be withdrawn if sleep driving is reported. To minimize withdrawal symptoms, dosing should be tapered slowly rather than a abrupt discontinuation. Paradoxical effects. When employed to treat anxiety, benzodiazepines sometimes cause paradoxical responses, which include insomnia, excitation, euphoria, a heightened sense of anxiety, and even rage. If these do occur, the benzodiazepine should be withdrawn. Respiratory depression. Benzodiazepines are weak respiratory depressants. Death from an overdose with oral benzodiazepines alone has not ever been documented. Therefore, in contrast to the barbiturates, benzodiazepines present very little risk as vehicles for suicide. It must be emphasized, however, that although respiratory depression with oral therapy is rare, benzodiazepines can cause severe respiratory depression when administered intravenously. In addition, substantial respiratory depression can result from combining oral benzodiazepines with other CNS depressants, such as alcohol, barbiturates, and opioids. The risk for abuse. Benzodiazepines have a lower abuse potential than barbiturates and most other general CNS depressants. The behavior pattern that constitutes addiction is uncommon among people who take benzodiazepines for their therapeutic purpose. When asked about their drug use, individuals who regularly abuse drugs rarely express a preference for benzodiazepines over barbiturates. Because their potential for abuse is considered low, the benzodiazepines are classified under Schedule 4 of the Controlled Substance Act. This contrasts with barbiturates, as most of those are classified a Schedule 3. Side effects in the use of benzodiazepines when pregnant or breastfeeding. Benzodiazepines are highly lipid soluble and can readily cross the placental barrier. Use of benzodiazepines during the first trimester of pregnancy is associated with an increased risk for congenital malformations, which include cleft lip, inguinal hernias, and cardiac anomalies. Use near term can cause CNS depression in the neonate. Because they may represent a risk to the fetus, most benzodiazepines are classified by the FDA as a pregnancy risk category D. Four of these drugs, astazolam, flurazepam, temazepam, and triazolam, are in the category X. Women of childbearing age should be warned about the potential for fetal harm and be instructed to discontinue benzodiazepines if they become pregnant. Benzodiazepines also may enter breast milk with ease and may accumulate to a toxic level in the breastfed infant. Accordingly, these drugs should be avoided in nursing mothers. Other adverse effects. Occasional reactions include weakness, headaches, blurred vision, vertigo, nausea, vomiting, epigastric distress, and diarrhea. Neutropenia and jaundice have occurred rarely. Rarely, benzodiazepines may cause severe allergic reactions, which include angioedema and anaphylaxis. So, benzodiazepines and other drug interactions. Benzodiazepines undergo very few important interactions with other drugs. Unlike barbiturates, benzodiazepines do not induce hepatic drug metabolizing enzymes. Therefore, benzodiazepines do not accelerate the metabolism of the other drugs. However, as a CNS depressant, the CNS depressant action of benzodiazepines add to those of other CNS depressants, again, are alcohol, barbiturates, and opioids. Therefore, although benzodiazepines are very safe when used alone, they can be extremely hazardous in combination with other depressants. Combined overdose with benzodiazepine plus a CNS depressant can cause profound respiratory depression, coma, and potential death. Patients should be warned against the use of alcohol and all other CNS depressants if they are on a benzodiazepine. Its risk for tolerance and physical dependence. In terms of tolerance, with prolonged use of benzodiazepines, tolerance develops to some effect, but not to others. No tolerance develops to the anxiolytic effect, and tolerance to hypnotic effects is generally low. In contrast, significant tolerance develops to anti-seizure effects. Patients tolerant to barbiturates, alcohol, and other general CNS depressants show some cross-tolerance when it comes to benzodiazepines. So, it's physical dependence, therefore. Benzodiazepines can cause a physical dependence, but the incidence of a substantial dependence is again considered low. When benzodiazepines are discontinued after short-term use at a therapeutic dose, the resulting withdrawal syndrome is generally mild and often goes unrecognized. Symptoms include anxiety, insomnia, sweating, tremor, and dizziness. Withdrawal from long-term, high-dose therapy can cause more serious reactions, which include panic, paranoia, delirium, hypertension, muscle twitching, and seizures. Symptoms of withdrawal are usually more intense with benzodiazepines that have a short duration of action. With one agent, alprazolam, also known as Xanax, dependence may be a greater problem than with other benzodiazepines. Because the benzodiazepine withdrawal syndrome can resemble an anxiety disorder, it is important to differentiate withdrawal symptoms from the return of the original symptoms of anxiety. The intensity of withdrawal symptoms can be minimized by discontinuing treatment gradually. Doses should be slowly tapered over several weeks or months. Substituting a benzodiazepine with a long half-life for one with a short half-life is also helpful. Patients should be warned against abrupt cessation of treatment. After discontinuation of treatment, patients should be monitored for 3 weeks for indications of withdrawal or recurrence of original symptoms. Acute toxicity. On an oral overdose. When administered in excessive dosage by mouth, benzodiazepines rarely cause serious toxicity. Symptoms would, however, include drowsiness, lethargy, and confusion. Significant cardiovascular and respiratory effects are uncommon. If individuals known to have taken an overdose of benzodiazepines does exhibit signs of serious toxicity, it is probable that another drug was taken as well. So, our preparations, dosages, and administrations. Preparations and dosages for insomnia are presented later in this chapter. However, preparations and dosages of benzodiazepines used for other disorders are presented in chapter 19, 20, and 28. So, what kind of routes do we give benzos in? Well, all benzodiazepines can be administered either orally. When used for sedation or induction of sleep, benzodiazepines are almost always administered by mouth. So, our oral preparations, therefore. Patients should be advised to take oral benzodiazepines with food if gastric upset occurs. Also, they should be instructed to swallow sustained-release formulations intact without crushing or chewing. Patients ought to be warned not to increase the dosage or discontinue therapy without speaking to their prescriber. For the treatment of insomnia, benzodiazepines should be given in an intermittent schedule, so 3 or 4 days a week, in the lowest effective dosage for the shortest duration required. This will minimize the physical dependence and associated drug dependency, causing insomnia. So, that brings us to our prototype drugs. For our sedative hypnotic drugs, benzodiazepines, benzodiazepine-like drugs, barbiturates, and melatonin receptor agonists. It's a good spot to hit pause so you can see all the names, though we'll be going through all of them as we continue this chapter. So, let's start with the benzodiazepine-like drugs. There are 3 benzodiazepine-like drugs that are available at this time: sulpidem, celeplon, and escitalopiclone. All 3 are preferred agents for insomnia. They are not indicated for anxiety. These drugs are structurally different from benzodiazepines, but nonetheless share the same mechanism of action. They all act as agonists at the benzodiazepine receptor site on the GABA receptor chloride channel complex. Like the benzodiazepines, these drugs have a low potential for tolerance, dependence, and abuse, and are classified as Schedule IV substances. So let's start talking about the first one, Solpadem. Solpadem, also known as Ambien, our most widely used hypnotic, is approved only for short-term management of insomnia. However, although approval is limited to short-term use, many patients have taken the drug for long-term with no apparent tolerance or increase in adverse effects. All Ambien formulations have a rapid onset and therefore can help people who have difficulty falling asleep. In addition, the extended release formulation of Ambien CR can help people who have difficulty maintaining sleep. Although structurally unrelated to the benzodiazepines, Ambien binds to the benzodiazepine receptor site on the GABA receptor chloride channel complex and shares some properties of benzodiazepines. Like the benzodiazepines, Ambien can reduce sleep latency and awakening and can prolong sleep duration. The drug does not significantly reduce time in rapid eye movement or REM sleep and causes little or no rebound insomnia when therapy is discontinued. In contrast to the benzodiazepines, Ambien lacks anxiolytic, muscle relaxant, and anticonvulsant actions because Ambien doesn't bind with all of the benzodiazepine receptors. Rather, binding is limited to the benzodiazepine 1 subtype of benzodiazepine receptors. Ambien is rapidly absorbed after oral dosing. Plasma levels peak in 2 hours. The drug is widely distributed, although levels in the brain remain low. Ambien is extensively metabolized to inactive compounds that are excreted in the bile, urine, and feces. The elimination half-life is 2.4 hours. Ambien has a side effect profile like that of a benzodiazepine. Daytime drowsiness and dizziness are most common, and these occur in 1 to 2% of patients. Like the benzodiazepines, Ambien has been associated with sleep, driving, and other sleep-related complex behaviors. At therapeutic dosages, Ambien causes little or no respiratory depression. Safety in pregnancy has not been established. According to the FDA, Ambien may pose a small risk for anaphylaxis and angioedema. Short-term treatment is not associated with significant tolerance or physical dependence. Withdrawal symptoms are minimum at best or absent entirely. Similarly, the abuse liability of Ambien is considered low. Accordingly, the drug is classified as a Schedule IV controlled substance. Like other sedative hypnotics, Ambien can intensify the effects of CNS depressants. Patients should be warned against combining Ambien with alcohol or other drugs that may depress the CNS function. Which brings us to Saliplan, or Sonata, which is the first representative of a new class of hypnotic, the pyrazolopyrimidines. This drug is approved only for the short-term management of insomnia. However, prolonged use does not appear to cause any type of tolerance. Like Ambien, Saliplan binds to the benzodiazepine 1 receptor site on the GABA receptor chloride channel complex, enhancing the depressant action of endogenous GABA. However, in contrast to Ambien, Saliplan has a very rapid onset and short duration of action, and therefore is good for helping patients fall asleep, but not for maintaining sleep. Saliplan is rapidly and completely absorbed after an oral dose. However, because of extensive first-pass metabolism, bioavailability is only about 30%. A large or high-fat meal can delay absorption substantially. Plasma levels peak in about 1 hour after administration and then rapidly decline, returning to baseline in 4 to 5 hours. Saliplan is metabolized by the hepatic aldehyde oxidase before excretion in the urine. Its half-life is just 1 hour. Because of its kinetic profile, Saliplan is well suited for people who have trouble falling asleep, but not for people who can't maintain sleep. The drug can also help people who need a sedative hypnotic in the middle of the night. Because of its short duration, Saliplan can be taken at 3 a.m. without causing any residual daytime sedation. Celepon is well tolerated. The most common side effects, however, include headache, nausea, drowsiness, dizziness, myalgia, and abdominal pain. Like benzodiazepines, Celepon has been associated with rare cases of sleep driving, as well as other complex sleep-related behavior. Respiratory depression has not been observed. Physical dependence is considered minimum, and the only sign being mild rebound insomnia at the first night after drug withdrawal. The next day sedation and hangover have not been reported. Similar to benzodiazepines, Celepon has a low potential for abuse and is therefore classified a Schedule IV drug. Which brings us to esopiclone, also known as Lunesta. Similar to Celepon and Zolpidem, it binds selectively with benzodiazepine-1 receptors on the GABA receptor chloride complex channel and therefore enhances the depressant actions of endogenous GABA. Lunesta is approved for treating insomnia with no limitation on how long it can be used. This contrasts with Celepon and Zolpidem, which are approved for short-term use only. Does this mean that Lunesta is safer than the other two drugs or less likely to promote tolerance? Not necessarily. It only means that the manufacturer of Lunesta conducted a prolonged 6-month study, whereas the manufacturers of the other two drugs did not do so. In that prolonged study, Lunesta reduced sleep latency and nighttime awakening, increased total sleep time and sleep quality, and had no significant effect on sleep architecture, and showed no indication of tolerance. Lunesta is rapidly absorbed after oral dosing, reaching peak blood levels in 1 to 2 hours. The drug undergoes extensive hepatic metabolism, primarily by CYP3A4. The resulting inactive or weakly active metabolites are excreted in the urine. The elimination and half-life is 6 hours. Lunesta is generally well tolerated. The most common adverse effect is bitter aftertaste, reported by about 17% of patients dosed with 2 mg and 34% of patients who were dosed with 3 mg. Other common effects are headache, somnolence, dizziness, and dry mouth. Rebound insomnia may occur on the first night after discontinuing the medicine. Similar to benzodiazepines and other benzodiazepine-like drugs, Lunesta has been associated with cases of sleep driving and other sleep-related complex behaviors. Rarely, Lunesta may cause anaphylaxis or angioedema. Lunesta has a low potential for abuse and is classified as a Schedule IV drug. Which brings us to Ramelteon, a melatonin agonist. Ramelteon, also known as Rosaram, is a relatively new hypnotic with a unique mechanism of action: activation of receptors for melatonin. The drug is approved for treating chronic insomnia, characterized by difficulty with sleep onset, but not with sleep maintenance. Long-term use is permitted. Of the major drugs for insomnia, Ramelteon is the only one not regulated as a controlled substance, so its therapeutic use. Ramelteon has a rapid onset of about 30 minutes and a short duration, and therefore is good for inducing sleep, but again, not for maintaining it. Therefore, there are no significant residual effects on the day after dosing, nor is there any kind of rebound insomnia when treatment is stopped after 35 consecutive nights of use. When approved, the FDA put no limit on how long it may be used. So how does it work? Its mechanism of action activates receptors for melatonin, specifically the MT1 and MT2 subtypes, which are key mediators of the normal sleep-wakefulness cycle. Sleep promotion derives primarily from activating MT1 receptors. Ramelteon does not activate MT3 receptors, which help regulate numerous systems unrelated to sleep. Selectivity for MT1 and 2 receptors explains why Ramelteon is superior to melatonin itself for treating insomnia. Ramelteon does not bind with the GABA receptor chloride channel complex, or with receptors for neuropeptides, benzodiazepines, dopamine, serotonin, norepinephrine, acetylcholine, or opioids. Its pharmacokinetic effects, therefore, absorption is rapid and nearly complete, although food may reduce both the rate and extent of absorption. Despite general good absorption, the absolute bioavailability of ramipril is actually very low, only about 1.8%, owing to extensive first-pass metabolism, primarily by the hepatic CYP1A2. Much of each dose is converted to an active metabolite, designated M2, that contributes to therapeutic effects. The half-life of the parent drug and active metabolite average between 2 to 5 hours. In patients who do have hepatic impairment, elimination may be delayed and the drug level may rise. Renal impairment, however, does not affect drug levels. It does come with some adverse effects, however. Ramipril is very well tolerated. In clinical trials, the incidence of adverse effects were nearly identical to that of a placebo. The most common side effects are somnolence, dizziness, and fatigue. According to the FDA, ramipril may share the ability of benzodiazepines to cause sleep driving and other sleep-related complex behaviors. Very rarely, patients had reported hallucinations, agitation, or mania. Ramipril can increase levels of prolactin and reduce levels of testosterone, so as a result, the drug has the potential to cause amenorrhea, galactorrhea, reduced libido, as well as fertility issues. If these do occur, the prescriber should be consulted. And post-marketing reports indicated a small risk for severe allergic reactions. Rarely, patients experienced angioedema of the tongue, glottis, or larynx. Some patients also experienced dyspnea and throat constriction, suggestive of anaphylaxis. Patients who did experience these symptoms should discontinue ramipril and never use it again. Its physical dependence and abuse. There is no evidence that taking ramipril leads to physical dependence or abuse. As a result, ramipril is the first FDA-approved sleep remedy that is not regulated by the Controlled Substance Act. Drug interactions. Fluvoxamine, or Luvox, a strong inhibitor of CYP1A2, may increase levels of ramipril to more than a 50% fold. Accordingly, the combination should be avoided. Weak inhibitors of CYP1A2 should be used with caution. Again, alcohol may intensify sedation, and therefore it ought to be avoided. It also comes with some precautions. Ramipril should be used in caution with a patient who may have moderate hepatic impairment and should be avoided by those who have severe hepatic impairment. Because ramipril promotes sedation, patients should be advised to avoid dangerous activities which include driving or operating heavy machinery. Its use in pregnancy and breastfeeding. Effects during human pregnancy were not studied. Until more is known, prudence dictates avoiding the drug during pregnancy. Ramipril is not recommended for patients who are nursing mothers. So that brings us now to our barbiturates. The barbiturates have been available for more than 100 years. These drugs cause relatively non-selective depression of CNS function and are the prototypes of general CNS depressants. Because they depress multiple aspects of CNS function, barbiturates can be used for daytime sedation, induction of sleep, suppression of seizure, and general anesthesia. Barbiturates cause tolerance and dependence. They have a high abuse potential and are subject to multiple drug interactions. Moreover, barbiturates are powerful respiratory depressants that can be fatal in overdose. Because of these undesirable properties, barbiturates are used much less than in the past, having been replaced by newer and safer drugs, primarily the benzodiazepines, as well as benzodiazepine-like drugs. However, although their use has declined greatly, barbiturates still have important applications in seizure control as well as anesthesia. Moreover, barbiturates are valuable from an instructional point of view. By understanding these prototypic agents, we gain an understanding of the general CNS depressants as a group. along with an appreciation of why barbiturates are no longer used for anxiety or insomnia. So, its classification. Duration of action influences the clinical application of barbiturates. The ultra-short-acting agents, methotrexate, are used for the induction of anesthesia. The short to intermediate-acting agents, segobarbital, are used as sedatives and hypnotics, and your long-acting agents, phenobarbital, are used primarily as an anti-seizure drug. So how does it work? Its mechanism of action of barbiturates bind to the GABA receptor chloride channel complex. By doing so, these drugs can 1. Enhance the inhibitory actions of GABA, and 2. Directly mimic the actions of GABA. Because barbiturates can directly mimic GABA, there is no ceiling to the degree of CNS depression they can produce. Therefore, in contrast to a benzodiazepine, these drugs can readily cause death by overdose. Although barbiturates can cause general depression of the CNS, they show some selectivity for depressing the reticular activating system, a neuronal network that helps regulate the sleep-wakefulness cycle. By depressing the RAS, barbiturates can produce sedation and sleep. Its pharmacologic effects. The central nervous system depressant. Most effects of barbiturates, both therapeutic and adverse, result from generalized depression of CNS function. With increasing dosage, responses progress from sedation to sleep to general anesthesia. Most barbiturates can be considered non-selective CNS depressants. The main exception is phenobarbital, a drug used to control seizures. Seizure control is achieved at doses that have minimal effects on other aspects of CNS function. Its cardiovascular effects. At hypnotic doses, barbiturates produce modest reduction in blood pressure and heart rate. In contrast, toxic doses can cause profound hypotension and even shock. At high doses, barbiturates depress the myocardium and vascular smooth muscle, along with the other electrically excitable tissues. Induction of hepatic drug metabolizing enzymes. Barbiturates stimulate synthesis of hepatic microsomal enzymes, the principal drug metabolizing enzymes of the liver. So as a result, barbiturates can accelerate their own metabolism and the metabolism of many other drugs by promoting synthesis of porphyrin. Porphyrin is then converted into heme, which in turn is incorporated into cytochrome P450, the key component of the hepatic drug metabolizing system, leading us to our tolerance and physical dependence. When speaking specifically on tolerance, when barbiturates are taken regularly, tolerance develops to many, but not all of the CNS effects. Specifically, tolerance develops to sedative and hypnotic effects, and to the other effects that underlie barbiturate abuse. However, even with chronic use, very little tolerance develops to toxic levels. In the tolerant user, doses must be increased to produce the same intensity of response that could formerly be achieved with a smaller dose. Therefore, individuals who take barbiturates for prolonged periods, be it for therapy or recreation, require steady increasing doses to achieve the effects they desire. It's important to note that very little tolerance develops to respiratory depression. Because tolerance to respiratory depression is minimum, and because tolerance does develop to therapeutic effects, with continued treatment, the lethal dose remains relatively constant, while the therapeutic dose climbs higher and higher. As tolerance to therapeutic effects increases, the therapeutic dose grows steadily, closer to the lethal dose, a situation that is clearly hazardous. So if you need a picture version of what I just said, here it is. An excellent spot to hit pause, and you can see the development of tolerance to the toxic and subjective effects of barbiturates. So, as a rule, tolerance to one general CNS depressant bestows tolerance to all other general CNS depressants. Therefore, there is a cross-tolerance among barbiturates, alcohol, benzodiazepines, general anesthetics, and certain other agents. Tolerance to barbiturates and other general CNS depressants does not produce significant cross-tolerance with other opioids, such as morphine. Which brings us now to the opposite side of physical dependence. Prolonged use of a barbiturate results in physical dependence, a state in which continued use is required to avoid an abstinence syndrome. Physical dependence results from an adaptive neurochemical change that occurs in response to chronic drug exposure. Individuals who are physically dependent on a barbiturate exhibit cross-dependence with other general depressants. Because of that cross-dependence, a person physically dependent on a barbiturate can prevent withdrawal symptoms by taking any other general CNS depressant, such as alcohol and benzodiazepines. As a rule, cross-dependence exists among all of the general CNS depressants. However, there is no significant cross-dependence with opioids. The general CNS depressant abstinence syndrome can be severe. Abrupt withdrawal from general CNS depressants is more dangerous than the withdrawal from opioids. Although withdrawal from opioids is certainly unpleasant, the risk for serious injury is considered low. In contrast, the abstinence syndrome associated with a general CNS depressant may be fatal. The following description illustrates how dangerous withdrawal from general CNS depressants can be. Your early reactions may include just weakness, restlessness, insomnia, hyperthermia, orthostatic hypotension, confusion, or disorientation. By the third day, however, a seizure may develop. Roughly 35% of patients experience a psychotic delirium. In extreme cases, these symptoms may be followed by exhaustion, cardiovascular collapse, and potential death. The entire abstinence syndrome evolves over approximately 8 days. Symptom intensity can be greatly reduced by withdrawing barbiturates and other general CNS depressants slowly. A long-acting barbiturate may be administered to facilitate the withdrawal process. Because of cross-dependence, phenobarbital can substitute for other CNS depressants and can therefore suppress symptoms of withdrawal. Because phenobarbital is eliminated from the body slowly, treatment permits a gradual transition from a drug-dependent state to a drug-free state. When phenobarbital is given to aid withdrawal, its dosage should be reduced gradually over 10 days to 3 weeks. So that brings us to our therapeutic use, especially in seizure disorders. Phenobarbital is used in seizure disorders. This drug suppresses seizures at doses that are essentially non-sedative, and these were discussed in Chapter 19. In insomnia, by depressing the CNS, barbiturates can promote sleep. However, because they can cause multiple undesired effects, barbiturates have been replaced by benzodiazepines and related drugs as treatment of choice for insomnia. Its adverse effects. Well, the big one, clearly respiratory depression. Barbiturates reduce ventilation by 2 mechanisms: depression of the brainstem neurogenic respiratory drive and depression of the chemoreceptor mechanisms that control respiratory drive. Doses only 3 times greater than those needed to induce sleep can cause complete suppression of the neurogenic respiratory drive. With severe overdose, barbiturates can cause apnea and death. For most patients, the degree of respiratory depression produced at therapeutic doses is not considered significant. However, in older adults, patients, and those with respiratory disease, therapeutic doses can compromise respiratory substantially. Combining a barbiturate with other CNS depressant intensifies respiratory depression. In suicide, barbiturates have a low therapeutic index. Accordingly, overdose can readily cause death. Because of their toxicity, the barbiturates are frequently employed as a vehicle for suicide and therefore should not be dispensed to a patient who has suicidal tendencies. Abuse. Barbiturates produce subjective effects that many individuals find desirable. As a result, they are popular drugs of choice. The barbiturates are the most prone to abuse are those in the short to intermediate acting groups, so your secobarbital, for instance. Individual barbiturates within the group are classified as a Schedule III drug, reflecting their high potential for abuse. Although barbiturates are frequently abused in the non-medical setting, they are rarely abused during medical use. there is a chance for acute toxicity. Acute intoxication with a barbiturate is considered a medical emergency. If left untreated, overdose may be fatal. Poisoning is often the result of an attempted suicide, although it can occur by accident, especially in the children and a drug abuser. Because acute toxicity from barbiturates and other CNS depressants is very similar, the discussion that follows applies to all the drugs. Your symptoms would include, in an acute overdose, the classic triad of symptoms: respiratory depression, coma, and pinpoint pupils. The three classic symptoms are frequently accompanied by hypotension and hypothermia. Death is likely the result from pulmonary complications as well as renal failure. So, treatment. Proper management requires intensive care unit requires an intensive care unit. With rigorous treatment, most patients may recover fully. Treatment has two main objectives. Again, the first being the removal of the barbiturate from the body, and then finally the maintenance of adequate oxygenation supplied to the brain and major organs. Oxygenation can be maintained by keeping the airway patent and giving oxygen. So, intubation. Its administration. Oral administration is employed for daytime sedation and to treat insomnia. Patients should be warned not to increase their dosage or discontinue treatment without speaking to their prescriber. Dosage should be reduced for older adult patients. When terminating therapy, dosages need to be tapered off. The management of insomnia. Insomnia can be defined as the inability to sleep well. Some people have difficulty falling asleep, and some have difficulty maintaining sleep. Some are troubled by early morning awakenings, and some have sleep that is not refreshing. Insomnia is transient for some people and chronic for others. In any given year, about 30% of Americans experience intermittent insomnia, and about 10% experience chronic insomnia. In the US, the direct cost of insomnia totals to about $16 billion annually, including the cost of testing, prescriber visits, and hypnotic drugs. So as a result of sleep loss, insomniacs experience daytime drowsiness along with impairment of mood, memory, coordination, and the ability to concentrate and make decisions. Chronic insomnia is a major risk factor for automotive and industrial accidents. Marital and social problems, major depression, coronary heart disease, and metabolic or endocrine dysregulation. The loss of sleep is often the result of a medical condition. Psychiatric disorders often disturb sleep, and pain can keep anyone awake. Sleep is frequently lost owing to concerns regarding to impending surgery and other procedures. So, the basic principles of management, therefore: cause-specific therapy. Treatment is highly dependent on the cause of insomnia. Accordingly, if therapy is to succeed, the underlying reason for sleep loss must be determined. To make that assessment, a thorough history is required. When the cause of insomnia is a known medical disorder, primary therapy should be directed at the underlying illness. Hypnotics should be employed only as an adjunct. For example, if pain is the reason for lost sleep, analgesics should be prescribed. If insomnia is secondary to major depression, antidepressants are appropriate treatment. If anxiety is the cause of insomnia, the patient should receive an anxiolytic. Our non-drug therapy. For many insomniacs, non-drug measures may be all that is needed to promote sleep. For some individuals, avoidance of naps and adherence to a regular sleep schedule is sufficient. For others, decreased consumption of caffeine-containing beverages may fix the problem. Still, others may benefit from restful activity as bedtime nears. If environmental factors are the response for lack of sleep, the patient should be taught how to correct them or compensate for them. All patients should be counseled about sleep fitness. There are rules to sleep fitness that are discussed here in the following box. And here is an outstanding spot to hit pause so you can see the rules for sleep fitness. And I'll make sure to stop at certain spots so that it makes sense to pause here. There we go. So 2 spots to hit pause. Research has shown that cognitive behavior therapy is superior to drug therapy for both short-term and long-term management of chronic insomnia in the older adult population. Cognitive and behavioral interventions include sleep restriction, control of bedroom environments, progression relaxation, and education about sleep hygiene. The American Academy of Sleep Medicine considers these interventions both effective and reliable, and therefore recommends them as a first-line therapy for chronic insomnia, even if drug therapy is also employed. So, our therapy with hypnotic drugs. Hypnotics should be used only when insomnia cannot be managed by other means. Therefore, before resorting to drugs, we should implement non-drug measures, and we should treat any pathology that may underlie inadequate sleep. Drug therapy of transient insomnia should be short-term, just 2 to 3 weeks. The patient should be reassessed on a regular basis to determine whether drug therapy is still needed. Escalation of dosage should be avoided. A need for increased dosage suggests development of tolerance. Hypnotic effects are lost in the course of treatment. It is preferable to interrupt therapy rather than elevate dosage. Interruption will allow tolerance to decline, therefore restoring responsiveness to treatment. In certain patients, hypnotics must be employed with special caution. Patients who snore heavily and those with respiratory disorders have reduced respiratory reserve, which can be a further compromise by the respiratory depressant action of a hypnotic. Hypnotic agents are generally contraindicated for the use during pregnancy, and these drugs have the potential to cause harm to the fetus, and their use is really an absolute necessity. Patients who are taking hypnotics should be forewarned that residual CNS depression may persist the next day. Although CNS depression may not be pronounced, it may still compromise intellectual or physical performance. When hypnotics are employed, care must be taken to prevent drug dependency insomnia, which is a condition that can lead to inappropriate prolongation of therapy. Drug dependency insomnia is a particular problem with older hypnotics and develops as follows. First, there is the insomnia motivates treatment with hypnotics, which follows with continuous drug use. Low-level physical dependence begins to develop. Next, upon cessation of treatment, a mild withdrawal syndrome occurs and disrupts the sleep, followed by failing to recognize the inability to sleep is a manifestation of drug withdrawal. The patient becomes convinced that insomnia has returned and resumes drug use, to finally continued drug use, which leads to the heightened physical dependence, making it even more difficult to withdraw the medicine in the future without producing another episode of drug dependency insomnia. So, to minimize this drug dependency insomnia, hypnotics should be employed judiciously. That is, they should be used in the lowest effective dosage for the shortest time required. Major hypnotics used for treatment. Insomnia may be treated with prescription drugs, non-prescription drugs, and alternative medicine. Among the prescription drugs, again, are benzodiazepines and benzodiazepine-like drugs are the drugs of choice. Older sedative hypnotics such as barbiturates are at this point rarely used. Non-prescription drugs and alternative medicines are much less effective than the first choice drugs and are therefore should be reserved for people whose insomnia is mild. The following table here shows hypnotic drugs differ with respect to onset and duration of action, and therefore differ in their application. Drugs with a rapid onset are good for patients who have difficulty falling asleep, whereas drugs with a long duration are good for patients who have difficulty maintaining sleep. Drugs such as flurazepam, which have both a rapid onset and long duration, are good for patients with both types of sleep problems. So here's a good spot to hit pause so you can see again the different types of time onset and its use in insomnia. So we're going to come back to benzodiazepines here for just a moment. Only 4 benzodiazepines are marketed specifically for their use of hypnotics. However, any benzodiazepine with a short to intermediate onset may be employed Benzodiazepines have multiple desirable effects on sleep. They decrease the interval to sleep onset, decrease the number of awakenings, and increase the total sleeping time. In addition, they impart a sense of deep and refreshing sleep. With most benzodiazepines, tolerance to hypnotic actions develops slowly, allowing them to be used nightly for several weeks without a noticeable loss in hypnotic effect. Furthermore, with most benzodiazepines, treatment does not significantly reduce the amount of time spent in the REM sleep cycle, and withdrawal is not associated with significant rebound insomnia. Two agents, triazolam and flurazepam, can be considered prototypes of the benzodiazepines used to promote sleep. Triazolam has a rapid onset and short duration, again making it a good choice for patients who have difficulty falling asleep. Flurazepam has a delayed onset and a more prolonged duration, making it an effective agent for patients who have difficulty maintaining sleep. However, because flurazepam has a relatively long half-life, the drug is likely to cause daytime drowsiness and therefore is not widely used today. Triazolam has a much shorter half-life than flurazepam, which is good news and bad news. Good news because it leaves the body readily. Triazolam does not cause daytime sedation. The bad news, because it is rapidly cleared, treatment is associated with two problems. Tolerance to hypnotic effects can develop quickly, in as little as 11 to 18 days, which is much faster than with other benzodiazepines, and second, it causes more rebound insomnia than other benzodiazepines. Which makes us jump back to our benzodiazepine-like drugs. So our sulfidam, citalopram, and esopiclone, also known as Ambien, Sonata, and Lunesta, are the drugs of choice for insomnia. All three drugs have the same mechanism of action as the benzodiazepines, and all three are just as effective. And they may be safer for long-term use. Furthermore, whereas benzodiazepines are contraindicated during pregnancy, the benzodiazepine-like drugs are not. All three drugs have a rapid onset and therefore can help people with difficulty falling asleep. Also, with sulfidam and escitalopram, effects persist long enough to help people who have difficulty staying asleep. In contrast, effects of citalopram fade too rapidly to help people with trouble staying asleep. However, citalopram is great for people who wake up in the middle of the night. Owing to its ultra-short duration, citalopram can be taken a few hours before rising and still not cause drowsiness during the day. Of the three drugs, only acetylpiclone has been proved effective for long-term use. However, even though long-term studies for citalopram and sulfidam are lacking, it seems likely that they too would retain efficacy when taken long-term. The pharmacology of benzodiazepine-like drugs was discussed already. Which brings us finally to ramipril. Ramipril is a melatonin agonist, approved for long-term therapy of insomnia. The drug has a rapid onset and short duration, and therefore is good for inducing sleep, but not for maintaining it. Ramipril does not cause tolerance or dependence and is not regulated as a controlled substance. And again, the pharmacology was already discussed previously. Which brings us to our last little section here, other hypnotics, the antidepressants. Trazodone, or Electro, is an atypical antidepressant with a strong sedative action. The drug can decrease sleep latency and prolong sleep duration, and does not cause tolerance or physical dependence. Trazodone is especially useful for treating insomnia resulting from the use of antidepressants that cause significant CNS stimulation, such as your fluoxetine, your Prozac, or bupropion, Wellbutrin. Principal adverse effects are daytime grogginess and postural hypotension. The basic pharmacology of trazodone is discussed in Chapter 25. Doxepin. Doxepin is an old tricyclic antidepressant, or TSA, with a strong sedative action. In 2010, the FDA approved a new low-dose formula for treating patients who have trouble staying asleep. The new formula is sold as Silanor. In clinical trials of adults with chronic insomnia, Silanor increased total sleep time and maintained the effect for more than 12 weeks. These benefits probably derive from blocking receptors for histamine. The initial dosage for a patient 65 and older was 3 milligrams, taken within 30 minutes of bedtime. The initial dosage for patients younger than 65 was 6 milligrams. Both dosages are much lower than the dosage used for depression, which is 75 to 150 milligrams per day. In the low dose, used for sleep maintenance, doxepin is well tolerated. The most common adverse effects are sedation, nausea, and upper respiratory infections. In a high dose that's usually used for depression, doxepin can cause hypertension, dysrhythmias, and anticholinergic effects. Owing to the risk for anticholinergic effects, Silanor is contraindicated for a patient with untreated narrow-angle glaucoma or severe urinary retention. In addition, Silanor is contraindicated for patients who have taken monoamine oxidase inhibitors within the past 2 weeks. Unlike benzodiazepines and its benzodiazepine-like drugs, Silanor has little or no potential for abuse and therefore is not regulated by the FDA, the Controlled Substance Act. Accordingly, the drug may be especially appropriate when the drug abuse is a concern. The basic pharmacology of doxepin and other TCAs are presented in Chapter 25. Which brings us to antihistamines. Two antihistamines, diphenhydramine and doxylamine, are FDA approved for the use as a sleep aid and can be purchased without a prescription. These drugs are less effective than benzodiazepines or benzodiazepine-like drugs, and tolerance develops pretty quickly in 1 to 2 weeks. Daytime drowsiness and anticholinergic effects are very common. Leaving us with alternative medicines. Of the alternative medicines employed to promote sleep, only one, melatonin, seems to be moderately effective. Melatonin is a hormone that helps regulate our circadian clock, the timekeeping mechanism that controls our sleep-wakeful cycle. Principal use for melatonin is insomnia and jet lag. Of note, melatonin is the only hormone that can be purchased without a prescription. The compound is available in health food stores, vitamin shops, and even airport newsstands. Melatonin is produced by the pineal gland, a structure located at the base of the brain. Secretion is suppressed by the environmental light and stimulated by darkness. Normally, secretion is low during the day, which begins around 9 p.m., reaches a peak time at 2 a.m. and 4 a.m., and returns back to baseline by the morning. Signals that control the secretion travel along the multi-neuronal pathway that connects the retina to the pineal gland. Several trials have indicated that melatonin promotes sleep. For example, doses of 0.3 to 1 milligram taken 1 to 2 hours before bedtime can hasten sleep onset and time to REM sleep, without reducing total time in REM sleep. Melatonin may also ease symptoms of jet lag by resetting the circadian clock to the new time zone. Of all treatments for jet lag, melatonin is the most widely studied. To date, there have been 11 double-blind, placebo-controlled trials. In 8 of these trials, melatonin produced significant benefit. Of the 3 negative studies, 2 were too small to permit firm conclusions, and 1 involved subjects whose baseline circadian rhythm may have been inappropriate for evaluation. When used short-term in low doses, so less than 2 milligrams, melatonin has no observable adverse effect. However, short-term use of a large dose can cause hangover, headaches, nightmares, hypothermia, and transient depression. In one case, reversible psychosis occurred with a huge daytime dose. Possible adverse effects of long-term use are still unknown. There are several other options, which include valerian root, chamomile tea, passion flower, lemon balm, and lavender, which all have very mild sedative effects, but the proof of benefit in insomnia is considered lacking. And that concludes our chapter here for today. As always, I thank you for listening, and I'll see you at the next chapter. Take care, and goodbye.